Good morning, everyone, and welcome to the GPE webinar series. My name is Jane Davis. I'm Senior Education Specialist for Gender Equality at the Global Partnership for Education, GPE. And I'm here at the GPE Secretariat in Washington, D.C., joined by my colleagues, the GPE webinar team, and who brought us this webinar today. We're also joined by a distinguished panel of experts presenting online from London, as well as here in D.C. The webinar series, as you may know, started in 2016 as part of GPE's Knowledge and Good Practice Exchange initiative that came about as a response to requests from GPE's partner countries for additional opportunities to exchange knowledge, good practice, and policy approaches that inform education policies and practices at the country level. The webinar series provides a forum for interactive dialogue between practitioners and partner countries and shines a spotlight on the innovative work being done across the global partnership to deliver better education results for every child and fulfill our shared vision of Sustainable Development Goal 4. The webinar series explores themes related to the strategic goals of GPE 2020, namely equitable learning, equity, gender equality and inclusion, system strengthening and partnership building. We also look at approaches for translating global commitments into country-level actions in line with our strategic plan, GPE 2020, and our gender equality policy and strategy. Before we begin the session today, may I highlight just a few housekeeping notes. May I ask you please to mute your microphones on your phones and computers. This cuts out any background noise. If you are facing connection issues, please let us know via email at webinars@globalpartnership.org. You can also ask your questions via email as well. We'll have a Q&A session after the presentations, so do keep sending your questions throughout the webinar via YouTube's live chat feature or by email. We'll try to get as many questions as we can during the QA session. Please mention your name, your organisation, and the name of the presenter, speaker to whom the question is directed. The session is also being recorded, and we'll send everyone participating today resources associated with the webinar, as well as a link to the recorded session. As you know, I think, today's session is the second in a three-part series that focuses on a very exciting new publication. This one, we looked at it last time, Optimising Education Outcomes, High Return Investments in School Health for Increased Participation and Learning, produced by Global Partnership for Education and the World Bank. Those of you who joined us for the first webinar will recall that the publication is a shorter version of this document, the third, volume 8, I should say, of the third edition of Disease Control Priorities, also known as DCP3, which focuses on health interventions in child and adolescent development. This shorter version is specifically tailored to the education sector. This groundbreaking work provides the evidence in one easy resource for affordable, cost-effective health interventions that maximise education outcomes. It illustrates that education and health are two sides of the same coin. Education promotes health, and good health promotes school attendance, participation and learning, especially for girls, and provides compelling evidence of the benefits that accrue from targeted interventions in health across critical phases of child development throughout the first 8,000 days of life, from early childhood through school age and up to adolescence, using the school as an effective platform. Just to quickly recap, the first webinar, part 1 of the series, introduced the main document, DCP3, volume 8, on child and adolescent health and development, and outlined the key messages which have important implications for education sector planning and investment. We also heard from our Chief Executive Officer of GPE, Alice Albright, how working cross-sectorally advances the strategic goals of GPE's strategic plan and helps achieve SDGs for health and education, as well as gender equality. We also touched on different platforms for health service delivery and essential packages of investments detailed in the volume, with a focus on schools and school-aged children. The recording and materials from this previous session are available on the web for those of you who were unable to join us live. Today's session will briefly recap on the key messages of the volume and focus on identifying an essential package of cost-effective, cost-beneficial and scalable interventions that address the health needs of school-aged children, optimising both health and learning outcomes. Before we begin our first presentation, allow me to introduce the distinguished guests on our expert panel today. On the line from London, we have Professor Donald Bundy, lead editor of Disease Control Priorities Edition 3, Volume 8 on Child and Adolescent Health and Development, and who is also Professor of Epidemiology and Development at the London School of Hygiene and Tropical Medicine. With Professor Bundy in London is Dr. Mina Fernandez, economist and associate advisor of Milieu Law and Policy Consulting Limited, a consultancy which is based in Brussels in Belgium. Also joining us from London, we have Dr. Elisabetta Orino of the Imperial College, a research fellow at Imperial College London. Finally, with us here in Washington, please welcome Dr. Bradford Strickland, who's co-author of the prologue to the volume and currently a consultant here at the Global Partnership for Education. May I now invite Professor Bundy to provide an overview of DCP 3, Volume 8, and the key messages emerging from the volume.
Okay, thank you, Jane, for that gracious introduction. That's terrific to be here again. This is our second webinar, as you said, introducing the Disease Control Priorities series, but very particularly this GPE supported edition focusing on the education sector. And I think this is going to be a very exciting webinar. We have two great speakers, two of the authors from Volume 8, Betta Orino and Mina Fernandez, who are going to talk about the thing that I think most people are interested in, certainly the thing we heard most about in questions and in emails after the last webinar, which is what's the content of the essential package? What are the things that need to happen in school? So we're going to get straight on with that. But I'm also very excited because this time round we are also having a Francophone audience, and I really want to welcome our colleagues in Francophonia. I worked for many years in West and Central Africa, and I recognize that much of the things we're going to talk about today will be very relevant to that area in particular. So welcome all my Francophone colleagues. I should say that these books are available in French, so make sure you can look for them. And I'll just I'm sure it'll say somewhere in the literature, but if you go to www.dcp-3, you can download any of the books that we talk about today. Okay, let me get into a brief introduction here. As Jane said, this is about the third edition of Disease Control Priorities. If I could have my next slide, please. This is a series of books that's been produced now for 25 years. The first volume came out in 1993 and was a report of the World Bank, the World Development Report on Health, the first report on health, called Investing in Health. It caused quite a stir when it came out because the issue of understanding how cost was important in deciding about where to invest your health dollars was a new idea at that time. Now it seems much more familiar, but there are still very few sources you can go to that tell you where you get the best return on your health investment. That was back in 1993. All the information in that report was published in the first edition of Disease Control Priorities the same year. 10 years later, the Gates Foundation also supported the World Bank in producing a second edition. So disease control priorities, second edition came out in 2006. And that wasn't just an update of the first edition, it actually expanded the range of issues. And for the first time, we had a real chapter there that was about child development issues and some mention of education. But it really isn't until this edition, this third edition that we're talking about today, which was launched last year and this year. And if I could have the next slide, please. This third edition is different from all the others in that it actually combines not one volume but 9 volumes. And those 9 volumes, the first 8 of them cover a range of health areas. The 9th summarizes the main conclusions. But the 8th volume, which is the one we're going to be talking about, actually focused for the first time on child and adolescent health and development. And as soon as we began to do that work, we understood that development had to include education. So this was the first time we've had a real attempt to have an in-depth analysis of that area, the area of education, the area of what goes on in the first 20 years of life. If I could have the next slide, please. For many of us, when we've been thinking about this, we wanted to have a single source of information, and GPE came along and said, let's publish a version of volume 8 that's specifically about education outcomes. And so this is the volume, the one so the slide I'm showing you now. You can see that the list of the editors of the original volume 8, so that's me, Donald from I was based then in the United States, Nailansi De Silva from Sri Lanka, Sue Horton from Canada, Dean Jameson from California, and George Patton from Australia. George Patton's name may be familiar to you because he is also the lead on the commission, the Lancet Commission for Adolescents' Well-being and Health. The foreword for the book was written by the ex-Prime Minister Gordon Brown, who's also the lead on the UN Commission on the Economics of Education, with a special preface by Julia Gillard, the chair of GPE, of the Global Partnership for Education, who talks very clearly about the importance of education, the importance of health for education, and the importance of education for health. And then with a prologue written by Louise Banham, Leslie Drake, and Bradford Strickland. And I know Brad has joined us in the DC office here today. So that's the volume you might want to get hold of a copy of. That's the one that covers all the information. What is that volume about? So let me briefly introduce that. So if I can have the next slide, please. The question here, the issue here that's addressed is one that many of you have looked at in terms of understanding early child development. Here we've got a graph. This is by Professor Heckman, a graph that was produced to make the point that if we look at age on the horizontal axis, if we look at age on the x-axis, and we compare that with return on investment, if the return on investment is highest very early in life, then we'll get a curve that looks like this, that investment in the first few years is going to give you a much higher return than later on in life. If, however, we start to look at what happens at different ages, we discover that, in fact, investment at all points in the first 20 years of life can be really important. And that although it's absolutely clear that this graph is completely correct in saying that investment in the early years is really important, is absolutely critical, it's also true that there are vitally important vulnerable periods during later life, throughout the first 20 years, which affect both educational outcomes and subsequent development. They determine how effective you become as an adult, and whether or not an individual is able to attain their real potential as an adult. So let's just have a couple of examples of that. The next slide, please. And this is a slide that shows on the x-axis, on the horizontal axis, for all three of these graphs, it shows age from 0 to 20. And this is really just to make a very simple point that it isn't only at the beginning of of life, it isn't only during those first 1,000 days, which are crucially important. It isn't only those 1,000 days that are important to development. And so if we take the top graph here, this is one that simply looks at growth rate, shows how height changes. We all know that when babies are first born, they have the highest growth rate that they'll ever achieve. But we can also see that when you reach puberty, there are massive changes. Well, we all know there are many changes that go on in puberty, changes in sexuality, in behavior, in emotion. But there are also changes just simply in growth. And we can see that growth suddenly happens in a dramatic way in those early adolescent years, different times for girls and boys. And we can see that if we look at those peaks are the same growth rates that we last see at about 2 years of age. So toddlers and these preteens are growing at about the same rate. But of course, the pubescent children are much bigger. There's much more biomass. So there's a huge change there in biomass, a very vulnerable period, a period when we need to be paying attention. But we also need to be paying attention, as I said, in many other ways, behavior, emotion, and so forth. If I drop down now to the bottom graph there, that's a graph that shows something about brain. Sorry, if we go back to the previous slide, please. So this is, I'm talking now about the previous slide. Thank you. So this is I'm talking here about the right-hand side of the graph. So this is now young people, 15s to 20. And what we see there is great changes in the brain. And many of you will have been told that the brain, but many of you will have learnt, at least I certainly learned when I was taught about this, that the brain was pretty well fully formed when a young baby was born. That's why we've got such big heads when we're born, to contain all this brain mass. What we now know, what the last at least 15 years of research have shown, is that there are dramatic changes in the brain throughout the first 20 years of life, including in this last phase, this last 15 to 20 years of age, when we see huge changes in behavior, what people always recognize as adolescent behavior. So huge changes in behavior, changes that often result in lifelong behaviors. That's when healthy behaviors for life get established. It's also when mental health issues first emerge. So again, this is a period that's clearly a very vulnerable period. It's clearly a period when we should be investing. So our main message from volume 8 is that throughout the 0 to 20 years of life, we need to invest in the health and development of children, and we need to be doing that alongside our investments in education. Well, what sort of investments should we be making? I'm just going to show you a slide. Next slide, please. A slide. This is actually taken from GPE, from the Global Partnership for Education's work, and it in part summarizes it's largely based on the results of the volume of disease control priorities. What we're looking at here is 3 different age groups: 5 to 9-year-olds, 10 to 14-year-olds, and 15 to 20-year-olds. The purple lines show interventions that are school-based. So this is what we're talking about as a school-age set of interventions from 4 to 15 approximately. And we'll be talking about those in some detail in a moment with Mina and with Beta. And then in orange, it shows an overlapping group of interventions, which are for adolescents, because children even in primary school become adolescents. So there's an overlap between the primary school, secondary school, lower school, higher school areas of development, and different sets of interventions in those different groups. I want to just point out that the Global Partnership for Education particularly introduced two additional ones here, the mental health interventions and the mental hygiene management interventions in the adolescent group. Clearly very important, but not ones for which we had a great deal of data to show in volume 8. But all of these issues are important issues in terms of the essential package. Finally, let me say that with the next slide, let's just look at some of the cost issues here. And this is the cost. What is the world spending on children in terms of their development? And what we've got here is age on the horizontal axis. And at 5 years of age, we've got the investment in children under 5, and we can see that's around $29 billion in low and lower middle income countries. So this is just low and lower middle income countries, and it's around 29 billion under 5. We go over 5, so we now look at children or young people between 5 and 20 years of age. We have one section about investment in health and the other about investment in nutrition. And what we see here is that the investment in health and nutrition is somewhere between 1.4 and 3.5 billion, and that the investment in education is about 210 billion. What's the message we want to make here? Well, first of all, the message is not that we need to move this money around. That's absolutely not the message. Our message is that all of these investments are currently too low. But what we can see is that we're investing in the under 5s in terms of health. We're not investing in the over 5s in the same sort of way. And our estimate is that we probably need to raise that to something around 9 billion a year from its current level. And that investment will maximally or optimally enhance the investment in education, that there's a real opportunity for synergy here between investments in health and investments in education. Do we think that this is all possible? Yes, we do. These are amounts that are achievable on current levels of spending. And my last slide is to kind of emphasize that. So this last slide is actually just very recent data from the government of Nigeria's program to provide a national school feeding program. These are terrific numbers: 75 metric tons of fish, 4.3 million eggs, 33,000 chickens, 355 cattle. And this is the amount required every week. This is the weekly demand to provide the school feeding program. And that's the amount that Nigeria is paying for out of their own budgets to cover the program. So that's, I think, a very positive message. It shows the kind of scale at which these operations really can be rolled out at, and it's an encouraging sign that we're not talking about small programs here. We're talking about reaching all the world's children. And with that, I want to move on to hand back to Jane and look forward to hearing from Mina and Betta about the details of the kind of interventions that can be important. Thank you very much.
Thank you so much, Professor Bundy, for that very informative overview of the volume. I think you've really highlighted for us the fundamental significance for all of us in the education sector, particularly the importance of investing strategically in health and education throughout the first 20 years in life. That's a key message there for the full development of human potential. And you've also highlighted the economic feasibility, scalability, and the benefits of the approach. We were planning to have questions next. I'm not sure, Michelle, do we have any questions coming in online yet?
No questions yet.
No questions so far. So can I encourage all of our viewers, the Anglophones and our colleagues in the Francophone world, please do send in your questions. We are very much looking forward to hearing from you. If we have no questions at this stage, perhaps I could call on our colleagues waiting on the line in London. And may I invite, please, Dr. Mina Fernandez and Dr. Elisabetta Orino to talk to us about identifying an essential package of cost-effective, cost-beneficial and scalable interventions that address the needs of school-age health. Thank you very much, Dr. Fernandez and Dr. Arena.
Hi, good morning everyone for who is in the other side of the pond, and good afternoon to all the European nations and Africans that are with us. My name is Elisabetta Aurino, and together with Mina present with us, it's a real pleasure for us to present our research on identifying and costing an essential package of health interventions for school-age children. So with Mia, we decided that I will start by setting a little bit the scene for our research, and then she will follow in the middle of the presentation to discuss the package more in detail. So first of all, I also would like to kind of stress for those of you that are in line and haven't had the chance yet to look at the DCP3. I have it here with me. I think it's an amazing publication, and it's really, I think, a Bible for those of us that are interested in health and education in low and middle income countries. So first of all, if you could go to the next slide, please. So first of all, why the school-age child? I know that you are, most of you are an educational audience, but I come mostly from a health background. And actually, for people that are more focused on health, the focus on the school-age children for this kind of analysis may be at the beginning a little bit surprising, because until very recently, most of the focus in terms of the health programs and interventions in low and middle income countries were on children below 5 years old, and especially on this critical window of opportunity that is the first 1,000 days. So that window that spans from conception to more or less about 2 years of age. Now we know that there is quite a large policy hype in terms of both health and nutrition, and obviously education for adolescents. So the school-age children in terms of health programs tended to fall a little bit within the track of health programming, and we saw it. I found one of the latest slides that Don just showed quite telling, because it was really showing the big gap that there is between interventions focusing on health in the school-age children demographics and the educational one. So there is a lot of space to really invest in these demographics. There is a big financing gap. And one of the biggest messages that the DCP3 proposed was really the fact that we need to continuously sustain interventions from early childhood to adolescence and adulthood in order to have human development outcomes in multiple dimensions. So it's really a life course approach. And if we could go to the next slide, please. I won't spend a long time here because Don gave an excellent overview, but it's really kind of to reiterate this idea of taking a life course approach to human development. So for the next slide. And again, on the life course approach, there are two things that are worth noting. First of all, that the inputs that a child receives in one stage directly feed into the outcomes of a specific stage, but also later on. So there is kind of what economists call self-productivity of inputs and outcomes. And then there is also another feature that is important to note, that is called dynamic complementarities. And this means that the health inputs that a child receives in a specific stage will feed into other dimensions of human development. Let's think about learning or psychosocial well-being in later stages. So there are both this self-productivity and this dynamic complementarities between investments in multiple domains. Next slide, please. So for us working on the school-age children, this is a very exciting moment because it's the MDGs led to the next slide, sorry, led to the largest expansion in primary enrollment in history. So this is, the previous one. There is this delay that I still need to get used to, sorry. So this is a very exciting time to invest in and think about programs that can reach school-age children, because this is the time in history in which most children ever have been enrolled in primary school. And indeed, schools can really provide a critical platform to deliver health interventions. And Professor Don Bundy and his co-authors in Chapter 20 of the DCP3 really spelled out clearly what is this economic rationale for investing in schools, using schools as a critical platform to reach school-age children. And you can see from this slide that there are different sensitive periods at different ages, and this heterogeneity can be really used in order to target better health programs at different ages, always using this school platform. Next slide, please. So this is a lovely slide that I always present in my presentation, because it really makes the point about the school as a platform. So this was developed. This picture was developed at the Partnership for Child Development, where both Mina and I worked in order to contribute to the DCP3, and it really shows how schools have multiple advantages in order to being a cost-effective health delivery system in low and middle-income countries. First of all, they are pervasive. Most communities everywhere have at least a school, and their schools, the educational infrastructure is much more pervasive, for instance, of health, basic health centers. So this pervasiveness provides multiple advantages in order to provide health programs. For instance, it cuts down on startup costs and also programmatic costs, because they're already there, and it can also accelerate program implementation. Also, teachers can be trained in order to deliver basic health interventions. And you can see here that, for instance, from the picture, there are teacher delivering basic antiparasital interventions. There is some water and sanitation. And obviously, there are all the educational related intervention. And another feature of this idea of the school as a platform to reach many children in low and middle income countries is that it goes beyond the children themselves. And in fact, it can be a tool to reach the broader communities through, for instance, health messages that are delivered through parent-teacher association meetings or through the children themselves. So it can really become a way to engage the broader community alongside health and educational outcomes. Next slide, please. The second thing, another thing worth noting about this school-age demographics is that it's a very broad age groups. It spans 10 years, and in these 10 years, many things happen, as Don mentioned earlier. And we really can, in order to think about programs, I think it's a useful starting point to break down these demographics a little bit more. And we could do that by focusing on middle childhood on the one hand, that is the age group between 5 and 9 years old, and early adolescence and growth spurt demographics that spans between 10 and 14 years. And I think it's important to recognize these differences, because these two groups may be very different between each other, as you may imagine, and also in terms of needs and and also outcomes that we may want to tackle. For instance, for the middle childhood group, this is a phase in which there is steady physical growth of body and also sensomotor brain function develops. And we may think some specific intervention tackling these specific groups. For instance, taking under control infections, working on diet quality, hunger, malnutrition, and also start to promote healthy behaviors. And then there is the early adolescence group, in which this is the phase in which puberty is really starting or is happening. And so we have very rapid physical growth and development, but also we have, as we saw earlier, very rapid brain development, and psychosocial well-being becomes a very critical issue. So we have the interventions that we could think of are also related to the ones of the previous phase, because obviously if we think from a life course perspective, every step kind of builds logically on the previous one. So obviously nutrition still is critical, especially because we are in a critical nutritional window of second opportunity for recovering from previous malnutrition. But also we may think at other things like vaccination, working on setting healthy dietary behaviors or prevention of non-communicable disease risk, and emotional development. So next slide, please. Oh yes, sorry, next slide. So yes, next again, sorry about that. Okay, so before we went and before we estimated the investment case for this package of intervention for school-age children in low and middle-income countries, we started from needs. Okay, so we wanted to understand which were the main health needs of these demographics. And one critical message that I would like you to take home from this webinar is the lack of data. So we found this is as I mentioned at the beginning of this talk, this demographic has been quite neglected, if you want, in terms of health intervention, and as a result, we know quite little. We could know more, let's say, about their needs. So we needed to face this data gap, which I think that is something we should take on board for future research and work. So we started by nutrition as one of the key needs of school-age children, and as I mentioned earlier, this is a critical period because children are preparing for puberty, and then there is this critical period of adolescence in which catch-up growth, which means that children can recover from previous malnutrition, is possible. So there is big nutritional needs for this specific stage. But also there is another factor that we should take into account, which is the rapid rise in overweight and obesity, even in low and middle income countries. So we have, on the one hand, the burden of undernutrition and macronutrient deficiencies, and on the other hand, we have the increasing risk of overweight and obesity. Next slide, please. So this is just a quick overview, very short overview of prevalence of stunting. That is a critical indicator of chronic malnutrition faced by children. And this is from the 4 countries of the Young Life Study, which is one of the few data sets available that can provide some statistics on the nutritional status of this demographic group. And these are the same children followed at different ages 5, 8, 12, and 15, and in different countries, so Ethiopia, India, Peru, and Vietnam. So as take-home messages from this slide, we could say, first of all, there is a lot of variation over time. So, and this within this indicator of stunting. So it means that children being stunted is not something that is necessarily going to be stable, but it can vary over a child life course. And also that there is a lot of heterogeneity in terms of levels, both in terms of both countries and ages. Next slide, please. These next slides points a little bit to what I was mentioning earlier, that relates to the changes in diet and related changes in overweight and obesity risk in low and middle income countries. This is a paper that Mina and I and Mary Penny, that is a colleague from the Instituto de Nutrición de Peru, worked on a few years back, and it takes data from 12 years old in the same communities, but at different points in time, and it asks how diets of an average 12-year-old are changing in different countries over time. And this is just to show you the increase in sugar consumption for an average 12-year-old. And you can see that this is particularly marked, for instance, in Ethiopia and in Vietnam, and particularly in rural areas. So we can really see that these changes in diets are occurring fast. The trends we are reporting here only focus on 8 years of gap. So this is happening fast, and so schools can really be a platform also to foster healthy dietary behavior since childhood and adolescence, because these tend to track over time. Next slide, please. This next need that we identified in terms of school-age children is infectious disease. And why this matter for education? Well, sorry, I didn't mention why nutrition matters for education, because I always work on the linkages between nutrition and education. It seems so key to me. But yeah, obviously children that are hungry cannot concentrate in school, and malnutrition malnutrition can affect their cognitive functioning and so on. In terms of infectious disease, children that have any type of parasites are often too tired to go to school, or they tend to be absent more frequently than their peers, and when their school cannot concentrate as much and focus on learning. So this obviously matter for educational outcomes. And when I looked at the data that other colleagues in the DCP3 provided, I was completely shocked, because we have a huge burden of disease of these parasites. In terms of soil-transmitted helminths, we have about 1 billion school-age children that live in areas that are affected. So it's a huge potential burden of disease. And the same with malaria. Again, Simon Brooker, that was the main author of this chapter, highlighted a data gap again. And but still, it is estimated that about 500 million school-age children worldwide are at risk of infection. And also, it's important to note that the burden is increasing because of demographics in the past years. Also, there are some vaccine-preventable diseases such as tetanus, cervical cancers that have that could be administered potentially in schools, and that can be administered at a cost-effective in a cost-effective way. Next slide, please. Then the third need that we identified was oral health, and this is important for education because children that suffer from especially tooth decay and other oral disease may be absent or may more frequently because of the pain, or this may affect their social-emotional development and the quality of interaction with the other children. And I was actually quite surprised when I looked at the data because there is this impressive statistics that tells us that between 40 and 90% of 12 years old in low and middle income countries suffer from tooth decay, and most of them unfortunately became untreated. So the schools, again, can be an important platform to address this, especially through educational campaigns. Next slide, please. And then the next need that we identify related to vision screening, and this is I'm very sympathetic with this one because I have problem with vision, and I think if this wouldn't have been addressed since I was a child, I think it would really have hampered my education because I remember I couldn't really see the blackboard and so on. And in fact, there are studies, for instance, this study in Brazil that shows that children with poor vision have the 10% higher probability of dropping out. And also, a very nice study by Paul Glebbe at the University of Minnesota showed that in China, poor vision lowered student academic performance. And this is, if you think about it, this is hardly surprising because if you cannot see the text or see the blackboard, it really becomes heavy to keep studying. So again, the burden of disease is the latest study that estimated the burden of impaired vision is quite old, not very old, but not super new either. So it was back in 2008, and it was estimated that 1% of school-age children worldwide suffer from visual impairment. But also there is a strong variation across countries, and this ranges, for instance, 1% in Malawi and 13% in China. And it's estimated that actually this is increasing over time. So I will leave it to Mina that will walk you through our more the nitty-gritty of the estimations. So thank you so much, and I look forward to your questions.
Hello, everybody, and thank you, Betha, for that wonderful introduction. Both Professor Bundy and Elisabetta have really laid out the case here for why we need to look at the school-age child, why we need to invest, and provided some perspective on in terms of health. And all these health conditions that Elisabetta pointed out have enormous implications for education. There's an issue of getting children to school. Indicators are now quite high thanks to the Millennium Development Goals. But there's also data out there showing that children at school are not learning while they're there, and they're not retaining and progressing in school. So we still need to understand what are the determinants of this, and research has shown that health is an important component. So what we try to do in this chapter is to go from this, yes, we know we need to do something, yes, there is a need for action, and we try to look at what are the practical implications. So what do we actually have to do? And what is that going to cost? And this was quite an exciting and interesting endeavor for us both. It was a very exciting opportunity. And could you switch the slide, please, by the way? Sorry, I just realized we're still on the vision slide. We're the two authors on the chapter, but this is a bit misleading because we actually had a lot of communication and interchange with other authors from other chapters, as well as the editors, including Professor Bundy. Also a lot of input from Professor Horton. This was very interesting for us because we got to learn about the state of evidence for all these different kinds of needs and to pull it together and try to make sense of it and to produce something that is useful for practitioners. So I'll move quickly to what we actually found. Could you move to the next slide, please? basically what we did is we looked through the research out there for all the needs, as Betha explained, and we identified a number of different interventions, and we focused on those for which those were that there was a strong base of evidence. We focused on ones that could be scalable and that would be the most relevant for the population, because the objective was to really have something that was economically feasible. And based on what we identified, we estimated the annual cost per year of delivering these interventions, and we looked at the types of benefits that could be gained in terms of educational and health outcomes. And basically, these overall costs are just rule of thumb estimates. I'll present them to you in a few minutes. In the end, the cost of an intervention of the essential package will vary by country, and it should also be tailored depending on the specific needs in that country. But what we try to produce here is a baseline, a starting point from which to understand what is considered important. And then from here, it can be further refined. So the next slide shows what we included in this essential package. In total, we identified 6 interventions, which are listed in the left column of the slide. Some of these have been mentioned by Beth already, so they shouldn't come as a surprise. They were school feeding, and this was mainly to address the undernutrition needs. Beth showed the high levels of stunting in the school-age population, so this intervention is primarily for that. We also identified health education, specifically on oral health prevention, and then on insecticide-treated nets for malaria. Our third intervention was vision screening, and this one was an interesting one. I'll talk a little bit about each of these once I present them. We also included deworming in the package, and this would be an annual dose to old children, not a targeted one, because we learned that to do a targeted approach to give pills only to children who are infected would be more expensive than actually just doing a treatment. And then we also included 2 vaccines. One was the tetanus toxoid booster, which is actually the most commonly delivered vaccine currently in schools, including in low-income countries. The prevalence is quite low, but it is the most common one. And then also we also included the HPV vaccination. And this one is currently not, the delivery right now is quite low, but we were quite surprised to find that cervical cancer, which is what the HPV vaccine is for, 80% of the prevalence is in lower middle income countries. So we saw here a huge need to be delivering this vaccine through schools, and particularly to target adolescent girls. So in total here we have 6 interventions, and I thought it's also interesting to mention what we didn't include here. We would have liked to, but we couldn't. One of those was water and sanitation, what is also known as WASH. There's many studies out there to show that poor water and sanitation is a predictor of infectious disease transport, and we would have. This was one we really considered. However, it's very expensive, particularly for water supply infrastructure, and it didn't meet our requirement for economic feasibility in terms of the cost. But of course, it'd be very important for health, but we could not include it. Another one was for malaria. We considered several different options here. One would be anti-malarial tablets, delivering these to children. However, as shown in another chapter of the DCP3, there isn't any effective treatment. The antimalarials are not effective, or evidence right now does not show they're effective for this population. And it also can be quite expensive. So we went instead for another approach, which would be health education, because what the research does show is that many communities do have insecticide-treated nets, and these are effective when used. However, they aren't really used, and this may be due to lack of knowledge or understanding of their effectiveness. So we included our treatment for malaria through this insecticide-treated net intervention, which is a bit cheaper and also targeting more the issue at stake. So I look forward to any questions you have on those interventions, and I'll move forward in the sake of time to talk about the cost. If you could switch the slide, please. Yes, so this is it's the same slide. I'm just highlighting the other columns. Oh, no, sorry, could you go back one slide? And basically what we did is we looked at the research out there to look at the costs of delivering these. And actually there's very good evidence out there for these interventions. And we estimated the cost per child per year in USD, and for each of these. Now, with the essential package, one of the other gains of delivering all these interventions together is that there can be efficiencies in delivering. One of the huge drivers of costs is actually the logistics of getting these interventions to children in schools. So by doing the essential package, we can actually gain some efficiency, and we can actually reduce the costs. And here we saw some efficiency gains, particularly in terms of, I believe it was the vaccines in health education, and as well as deworming in health education too. And here there can be gains in terms of training the teachers. Instead of training them on one intervention, you can train them on multiple interventions to support the delivery. And also there can be gains in terms of the actual logistics of getting them to schools. So the cost of the essential package, one can think of it as the total cost of each of these, or there can actually be some cost savings in there. Okay, next slide, please. And here in this slide, I just wanted to provide a visual depiction of what the cost of these interventions are as compared to their benefits in terms of education and health. One of the key benefits for school health interventions is keeping children in school and improving the quality as well as the quantity of education. So we keep them in school longer, and they learn more while they're there. And what this does is it increases their rate of return on education. This is what's known in economics. Basically, what this means is that we can expect higher employment levels and higher income levels. And this is how we estimated the benefits. Primarily, there's some other benefits, but really the rate of return on education is the main one. And one of our key sources shows that the rate of return for just one additional year of education is a 12% increase in earnings. So this 12%, and this is just for 1 year. So now you have a child who is entering the workforce, and they have an increased capacity over their entire career working. So it's not just 12% in 1 year; those benefits are experienced over their entire working life. So here we can see a huge benefit from just this investment in this school age period. Yes? Could you switch the slide, please? And just going back to the costs, we also estimated the cost for lower income countries and lower middle income countries. That would be the last columns. And in total, I'll just sum it up for you. It's $10 per child per year in lower income countries, and $24 per child in lower middle income countries. So, and then these figures here, the overall figures are very small compared to the figures Professor Bundy showed us earlier. In total, it's about 117 million for lower income countries in total to give the essential package to all of them. And this compares with the figures he presented earlier, which are far smaller. So these sound large. 117 million sounds large until you put it into the context of what is currently being spent and what else is potentially can be gained from this investment. So I think that's it for my side. And we look forward to, if you go to the next slide, I also show a visual, maybe this is easier to understand. This just shows the breakdown in the cost again of the package for the different interventions. And here you'll see that school feeding is the most expensive for both low-income countries and lower middle-income countries, and the other ones are a bit smaller. But overall, it's about $10 for low-income countries and $20 for lower middle-income countries. So, thank you, and we look forward to your questions.
Thank you both so very much for your presentations, Dr. Arino, for outlining the essential packages of investments that leverage health and education outcomes for school-aged boys and girls, using the school as an effective platform. And you really mentioned how we need to tailor these specifically to different age groups for maximum impact. And many thanks to you, Dr. Fernandez. You've really highlighted the economic feasibility of the interventions and the evidence base for their costs and benefits. Michelle, have we got some questions coming in now?
No questions, but a lot of interest. Thank you, Jane.
Okay.
A lot of interest also in the materials, and just to let folks know on the webinar that the materials will be circulated in both English and French to all of the participants. So for those of our French colleagues who are following, I know there's a great interest in the documentation in French as well that will be made available. Thanks, Jane.
I actually have a question, and I think, Brad, you've also got a couple of questions. Maybe, I don't know, something that I'm particularly interested in. I think people who were part of the first webinar noted my particular interest in the adolescent stage of life. I think, you made it very clear that there are critical changes that happen to boys and girls as they enter this critical adolescent stage in terms of their brain development, in terms of their physical development, social, emotional development. And I'd be very interested to know whether you have highlighted differentiated approaches that are tailored to the specific needs of adolescent girls, for example, and whether you can tell us about any packages of interventions that particularly target girls, adolescent girls, and have specific benefits for them.
Nina, do you want that I give you start to respond and then you add, or?
Yes, I should have directed it to you, I think, please, Elizabeth. If you've got any thoughts on that.
I was just thinking first that this is just 1 out of 3 packages that are defined in the Disease Control Priorities Project. There's also one on early childhood development. This comes in the middle, and then there is an adolescent package. So really, there's 3 packages defined along, and it provides a continuum of care over the period that Professor Bundy laid out at the beginning. So the first one, 8,000 days, there are 3 packages. But given that the school-age population does include part of that early adolescence, we do try to address it. So perhaps Beth can talk a bit about that. Is that okay, Beth?
Yes,
great.
Thanks. Thank you, Mina. So, with regards to your question, we address it partially because, as Mina said, we needed to deal with quite a large population group, and actually we needed to work with the trade-off of different interventions, and I think we attempted to do something that was quite useful for all the different age groups and genders. So the mid-childhood and the adolescent and adolescent boys and girls. But with regards to adolescent girls specifically, I think the interventions that could be most relevant and actually targeted to them only is the HPV vaccine, which I was also very surprised about the burden. 80% of cases of cervical cancer are in low and middle income countries. So it's really important to provide the vaccine to the girls for their life course health. And obviously, all the other interventions are critical, and particularly, I think, the nutritional one, because in adolescence, it's not just about the nutrition of the girl that is going through menarche and a plethora of different changes and very rapid growth, but also the nutritional status of adolescent girls that matters also for the next generation of children. And so I think really sustaining nutrition during this stage is particularly critical for the adolescent girls and the next generation of children in order to break the transmission of malnutrition from one generation to the other. Also, something that can be considered always remaining the field of nutrition is iron supplementation or other micronutrient supplementation, because we know that especially during menarche and puberty for girls, there may be increased micronutrient requirements, especially for iron. Anemia is a critical issue in many low and middle income countries where the diet is not varied enough, and then where the burden of parasitic infection is also large. So, and obviously this has repercussion with the cognition and learning, because children that are micronutrient deficient have lower capabilities to concentrate in school, and have lower cognitive skills. So obviously this has a repercussion on education. So I think yes, we try to be as comprehensive as possible, because our task was really to address a broad age demographic in many different contexts. But I agree with you that this is a very specific target population that should receive some kind of ad hoc care and health interventions.
Thank you so much for that very comprehensive response. We really appreciate that. Michelle, do we maybe have a question coming in now?
We do, Jane. A couple of questions, actually. The first one, and both of these questions are for Mina and Elisabetta. The first question is about the method that's used for preventing malaria, and if the costs for that prevention are calculated on the real cost, including foreign aid subsidization, or on subsidized costs. And then the second question is related to school feeding, and whether it is done through the supply of food or through the production of food in school gardens. Thank you. And the questions are coming from Jean-Jacques Schul. Thank you very much.
Shall I respond to that one, Beba? No? Okay. So thank you very much for those questions. They're very good ones. In terms of the costs of the insecticide-treated nets, we used the estimates that were available in the malaria chapter of the DCP3, and I believe they are comprehensive. It's the cost for. I'm not sure if the cost for training of the workers are there, but it's the annual cost for delivery for sure in there. And it's basically the time for teachers to deliver this this information to children, and also materials, if I recall correctly. But the correct citation is in the chapter. And as for school feeding, this is a comprehensive estimate for the cost of the ration, as well as the delivery to schools. And the estimates are based on the conventional WFP approach for procuring foods, through various methods, but it could be from institutional sources, and delivering them to schools. It's an average value. The cost of school feeding can vary tremendously based on the model, if it's using school gardens, where the context, the ration. There's many. It's a huge area in itself, and I would urge Jacques to have a look at the school feeding chapter for more information about this. Get into the issue of local training and the implications for costs.
I'm sorry, could the speaker repeat the last part of her intervention, because we did not hear it. This is the French booth. Thank you.
No problem. So with school feeding, based on averages from based on that use different models. School feeding can be delivered. There's many different approaches. It can use a centralized approach, a decentralized approach. The cost can vary by the type of ration in terms of how the food actually gets there. So the figure we have here, the $8.2, is an average across all these different kinds of models. It's not specific to any particular kind of model. However, this issue is discussed more in a chapter specifically about school feeding that is in the same volume. I think it's chapter number 12. And in this one, we do explore the costs, how these costs vary by different procurement models that include school gardens. So I would urge Jean-Jacques and any others who are interested in this issue to have a look at that chapter for more information.
Do we have time for one more question?
I would like to ask a question if we do.
Please, Fred, I think we do.
So, Dr. Aurino, it sounded like when you were making your presentation and you had the diagram of the school and communities working together, that you were suggesting that a school health framework or a school health policy as a platform for delivery of school health interventions was a formula for long-term sustainability and cost effectiveness. And I was wondering if you would say a bit more about that, or if Dr. Fernandez would also like to say something about that. Thank you.
Yeah, thank you so much for touching this critical issue that is the one of sustainability. And I think, yeah, perhaps Mina then can add something, but the idea is really to integrate the school health nutrition platforms within the broader community. And this, from an educational point of view, is also critical to reach all these groups of children that are the ones that have been left behind from the massive increase in primary school enrollment from the MDGs. Still, we have millions and millions of children that are often the ones that are the most vulnerable, that still didn't make it to school. And the same with the demographics, like the adolescents that tend to drop out at the end of primary. So I think it's really critical that the messages that are delivered and the interventions that are delivered in school can reach more broadly the community of parents, of the siblings, and the other children that are not in school, because this would be a critical platform to ensure sustainability, and also reaching the ones that perhaps need the most these interventions. And this, again, I think goes back to the point on adolescent girls. For instance, I work a lot in the context of India, and although most children stay until end of primary, then the big gap now is keeping kids into secondary, and particularly girls or other lower caste groups, lower socioeconomic status group, they tend to drop out. So by trying to use the school to reach the broader community, you can reach these hard to reach groups. So that's why I think it's really critical. I don't know if Mina wants to say something more.
Yes, actually, I'd like to add a few words. It's a fantastic question, Brad. And in terms of the costs, what we try to do is capture what it would cost for governments to deliver these interventions. And because the idea is that a school can be a sustainable platform, and it's sustainable financially as well as operationally, and that governments can actually deliver these interventions through the school platform, and we wanted to provide the estimates of the cost for doing so. So this idea of sustainability and a comprehensive approach is reflected in our economic methodology as well here.
Could I ask a quick follow-up? Dr. Fernandez, does that suggest then that a school platform, a school policy, some sort of framework is necessary for delivery of these interventions at the school level? It sounds like that's what's implied.
Indeed. There's definitely, that's part of it. So we talked, so there's logistical as well as the policy, we need policies in order to promote that sustainability. So indeed, the need for school health nutrition policy frameworks, and also integrated with education sector plans. And we talk about this as well as in the chapter, I believe, or maybe it's in other parts of DCP3. But yes, that's also very important to the sustainability. And in terms of the economic side, it can also be important to have a budget line for these activities. That can also promote the sustainability. But in order to have a budget line, one needs to have an understanding of the cost. So that is our hope with this chapter, is to facilitate that activity.
Thank you.
Thanks so much to all of you out there for your questions, and to our presenters for your informative responses. For our final presentation today, I'd like to invite Dr. Bradford Strickland to give us a preview of what's coming up next in our third and final webinar of the series. Thank you, Brad.
Thank you, Jane. So my job is very simple, just to point out what's coming up in the next webinar. This, of course, is the second of 3 that are interrelated. The next webinar is on June 28th, and we encourage everyone to pre-register for that if you can. Thanks very much for the presentations today. They've done a great job detailing more of the technical rigor and requirements for the essential packages and delivery of them. Now, the next webinar will focus on, more specifically, nutritional interventions in the middle childhood that would help to reverse the effects of cognitive deficiencies in early childhood. So I think that it's a very nice follow-on to what's been discussed today. Of course, as both Dr. Arino and Dr. Fernandez were saying towards the end, these are looking at methods for leveling the playing field, or making sure that all children have an equal chance at education, even disadvantaged kids who come from economically disadvantaged households, or in many cases, girl children who get less food at home or less medical attention than some of their siblings. The webinar, next webinar, will also cover something of what ministries of education are already including in their education sector plans, and how we might expect that to, or anticipate that it would increase given the new evidence and essential packages that are laid out in DCP3 Volume 8. This is a great resource that actually helps ministries operationalize activities and move them forward. So that would be included in the next webinar. And then we would also anticipate there's a real desire to look at equity, gender equity and gender equality in education. In addition to leveling the playing field for all students, there's a real need to boost activities that focus specifically on adolescent girls, as Jane has mentioned in one of her questions. And we're planning to look at those areas that have been identified repeatedly in dialogue with partner countries around issues with DCP3 and menstrual hygiene management, clean water, promotion of sanitation, those aspects that GPE, in fact, in GPE-funded grants, these things are feasible and can be covered in a grant when ministries are applying. So even if the cost effectiveness looks intimidating, the costs look intimidating, and they don't look like the most cost-effective interventions, that doesn't mean that they shouldn't be included in an ESP implementation grant. So that's something we'll look at again in the next webinar. I would like to say that, again, thought leaders in the field, the contributors to this volume, will be leading these presentations in the next webinar. And of course, remind everyone that you can download the entire series of the DC Disease Control Priorities, 3rd edition, from the key website, which will be provided as a follow-up to the webinar today. Thank you very much.
Thank you so much, Brad, for sharing this preview and providing us with a foretaste of what we can look forward to in our next and final webinar in this series. That actually brings us to the end of today's presentations. I'd like to thank all of our expert presenters and all participants for joining our webinar today. We do hope you found it very informative. And perhaps just before we sign off, to recap perhaps on some of the key takeaways, I think for me, what we've really heard today from all of our speakers is that health and education go side by side. And we as education and health actors, we need to work together to synergize our investments for maximum impact. We've heard that the school provides an effective platform for what I think it was you, Elisabetta, described as a continuum of care from early childhood through school age right up to adolescence. And it's not a question of like one silver bullet, but we need to tailor a holistic package of interventions, of its investments at these very strategic points in the first, not just the first 5 years of life, but the first 20 years of life. And that if we do this, we'll enable children to reach their full human potential. And this obviously is a benefit not only to the individuals themselves, but also to the human development wealth of nations. I think excitingly, we've heard that these interventions are scalable, they're affordable, and they're also sustainable. So it's not only the right thing to do, but it's also smart economics. I think, this discussion, this volume and the interest it's generated, I think it marks a critical, exciting new direction for GPE. And we're all very much looking forward to reaching out further to our health partners and exploring ways in which we can strengthen our collaboration. As we've heard, the materials from the webinar will be shared. This includes all the presentations and a summary recording and a written summary of the discussions, and we're really looking forward to joining together for the next webinar. You said 28th of June, Brad. Please save the date. Meanwhile, goodbye from all of us here in DC and over in London. Many thanks for being with us today.